All right. And I don't have a timer here, so if I'm running over, please don't hesitate to tell me. So this was the face of head and neck cancer, and now this is the current face of head and neck cancer. What we see is that the incidence of head and neck cancers overall has declined in the United States, yet we see a rise in oropharynx cancers in the United States. When we look from 1975 to 2012, you see that there's been over 60% fold incidence rise in oropharynx cancers in the United States. This has been predominantly among men, whites, and across the age groups. When we look at incident curves in the United States stratified by gender, you see that incidence is much higher among men than it is among women. And you see that there's a birth cohort effect where the risk of being diagnosed with an oropharynx cancer is increased in more recent birth cohorts. So if we take example of 55 to 59-year-olds being diagnosed with oropharynx cancer, the risk of being diagnosed with oropharynx cancer for those born in the 1930s is here, whereas the risk of being diagnosed at the age of 55 to 59 in more recent time periods is significantly increased. So we see that the incidence is increased among men versus women and in more recent birth cohorts. Well, when we initially described this disease, we found that incidence was increasing among younger age groups, but recently people have noted that there's also an increase among older age groups, and that these incidence trends also apply around the world. So HPV is responsible for these incidence trends. Human papillomavirus is the most common sexually transmitted infection in the United States. It's integrated into the cervical cancer algorithm for screening, and it's really analogous with Pap testing, has essentially replaced it in most places. HPV-16 is the most common type found in oropharynx cancers in the United States. So in our early work in a case control study, we showed that sexual behavior and biomarkers of HPV infection, which are really surrogates for exposure to HPV infection, were strongly associated with the diagnosis of oropharynx cancers. Not surprisingly, the same risk factors apply to presence of oral HPV infection. Increased sexual exposure by number of sex partners, early sexual debut, as well as other cofactors appear to be associated with oral HPV infection. History of sexually transmitted infections such as herpes simplex 2 is also associated with the diagnosis of HPV-positive cancer and other sexual behaviors. So we now recognize that HPV-positive cancers are distinct from HPV-negative cancers. They're distinct in terms of risk factors and clinical demographic profiles, diagnosis, and it's relevant at the time of prognosis. So at the time of diagnosis, HPV-positive patients tend to be younger than HPV-negative patients. That is evolving, so I'll go on to actually explain that shortly. The majority of patients are men, white. They tend to be married, higher socioeconomic status, and they tend to be healthier than HPV-negative patients. Statistically, when we look at it, there's a greater number of non-smokers and lower tobacco exposure among HPV-positive patients than HPV-negative patients. Clinically, HPV-positive patients are distinct from HPV-negative patients in terms of the primary site. So HPV-positive tumors tend to arise in the tonsils or base of tongue where the lymphoid tissue exists. HPV-unrelated tumors arise in non-lymphoid tissue of the oropharynx. And these are really hot spots for each of the types of tumors. HPV-positive tumors tend to be smaller than HPV-negative tumors, and they're more likely to have a cystic lymph node, although not exclusively cystic lymph nodes. So while incidence is higher among men than women, this will probably change with time. We did a large study at Hopkins, UCSF, and Mount Sinai. It was a case control study, and among the cases, we evaluated changes in HPV positivity over time. We found that just like HPV positive tumors are increasing over time among men, they're also increasing among women, whether you test for P16 or in situ hybridization. So what this tells you is that in this day and age, if a woman shows up in your clinic with an oropharynx tumor, chances are it's going to be HPV positive. So although risk is higher, incidence among men, prevalence is also increasing among women. Similarly, when we look at race, we see analogous trends. So just as prevalence of HPV positive tumors is increasing in the United States among whites, it's also increasing among non-whites across the race categories. And then when we've looked at this by age to see whether or not the previous incidence trends of increasing incidence of oropharynx tumors in older age groups could be explained by HPV positivity, we found that using the same case control data, that HPV positive tumors were increasing across the age groups. So just like we see an increase in HPV positive tumors among younger patients, we also see a rise among older patients. And then when we looked at it, the National Cancer Database, we again reproduced the same data to demonstrate that older age groups were also being affected. So since I want to convey that things have evolved since we first described this in the mid-2000s, late 2000s, when we first looked at the data, we saw that HPV positive patients were younger, and it was really kind of this blip here. And we see over time, looking at data at Hopkins, that that the median age of HPV positive tumors has actually increased over time. And we see a similar rise when we look at the National Cancer Database to show that HPV positive patients are increasing. So while initially, when we first described it, HPV positive patients were younger, that gap is lessening now as we see an increase in the age of HPV positive patients. So we found this to be striking because why would we be seeing more and more older patients? Isn't it the same cause, right? Sexual exposure. So we looked at our older patients in the case study of the cases from the case control to evaluate whether or not there are any demographic difference among HPV positive and HPV negative, among older and younger HPV positive patients. So these were just HPV positive patients, and we stratified by age. And what we found is that there was no difference in terms of distribution of gender, race, living with a partner, socioeconomic status, and as you would expect, since sexual exposure is the main driving risk factor for HPV positive oropharynx cancer, there was no difference in the number of partners, any which way we broke it, among young, middle, older age groups. But the difference that we found was that the age of sexual debut was different. So older patients tended to have a later age of sexual debut. They also had differences in first sexual encounter. And when we looked at intensity of sexual exposure, older patients had a lower intensity of sexual exposure. So this is kind of a new variable that we made up, which is analogous to pack years. We think about pack years giving us a cumulative exposure of tobacco exposure over time in intensity. So we did the same thing and looked at number of lifetime partners per 5 years of age after sexual debut. And what you see is that it differs across age groups, with younger age groups basically having higher intensity or a burst of initial sexual exposure, and therefore they're presenting earlier. And that was really the only difference in terms of sexual behaviors that we found in terms of younger versus older patients at the time of presentation. So when we think about HPV positive tumors, they have a distinct pathologic signature. They tend to be well differentiated, basaloid, non-keratinizing, and arise from the lymphoid crypts. They don't have any adjacent dysplasia. We know that we can have direct testing using in situ hybridization or P16, and that P16 is a great surrogate for HPV positive tumors. In this case control study, what we found is that P16 has very high sensitivity and good specificity for oropharynx HPV positive tumors. And the thing that's interesting is that that does not apply across all age categories. So we know that P16 is a reliable surrogate for HPV positive tumors, and we expect most of them to be HPV 16 positive. But when we looked across the age groups to see the distribution of HPV types in the tumors, what we found is that the largest number of non-HPV 16 positive tumors were in the older age groups, and most of the HPV 16 positive tumors were in the younger age group. And when you go back and dig through the literature, there is this notion that non-HPV 16 positive tumors are not doing as well, and if you look at the age distribution, it actually lines up with the previous literature. So it appears that there is a difference in terms of the tumor for HPV 16, HPV positive older patients. So in terms of prognosis, we've shown a while ago, and actually I put this in here because Harlan Pinto was one of the biggest accruers to ECOG 2399, and he was very nice because he took all of my phone calls when I was a T32 resident as I was trying to get these tumors and test them for HPV because no one was doing it at the time. So anyway, it was an induction trial looking at concurrent chemoradiation after induction chemotherapy, but it allowed us to, at the time, in the first multi-institution prospective study, showed that HPV positive tumors have better prognosis than HPV negative tumors in terms of overall survival and progression-free survival. And it was the first study to show that it was a robust, independent, prospective biomarker for prognosis, independent of stage. So RTOG 0129 is a study that you guys are all probably familiar with, and that really was testing standard fractionation versus accelerated fractionation. It was a cooperative group study, and it's actually, we've been very fortunate because it gives us this large data set. Keong Ng and Maura Gilson, along with Quinn Lee, then showed that the survival differences continued. They persisted at 3 years when they looked at the ECOG 2399 results. And so this was one of the larger studies to corroborate our initial findings in terms of HPV being an independent marker of prognosis. The other exciting thing that came out of RTOG 0129 was this recursive partitioning analysis. And what that did is it helped stratify HPV positive and HPV negative patients into low, intermediate, and high risk patients. So low risk patients are those who have the highest survival. Intermediate risk patients are the HPV positive tumors with smoking history and advanced nodal disease, or intermediate risk. And high risk is most of the HPV negative patients. And the exciting thing at the time when this paper came out was that the low risk group was a possible group to de-intensify. And that's really where therapeutic de-intensification first kind of was born. And it was posited that the low risk group might be a group that is doing so well that we might be able to reduce the amount of therapy for that group and maintain the survival, but reduce the morbidities of treatment. We've done that as a community, but we haven't really asked patients what they wanted. We have tried to reduce, we're doing de-intensification trials really to reduce the long-term side effects, including swallowing and xerostomia. But when you ask patients what is it that they prioritize at the time of their treatment and even afterwards, it's consistently cure. That's the number one priority for these patients. And then after that, you see survival is second. And then the rest of these priorities, which are using a validated instrument, the Chicago Priorities Scale, are all kind of lumped together with overlapping confidence intervals. And cure remains the priority, independent of age. And the in favor of de-intensification is that patients after treatment have increasing regret with increased number of modalities of treatment that are used at the time after treatment. So we have proceeded with therapeutic de-intensification trials. There are many of them, and we're waiting for some of them to read out, which will happen probably in the next year or two. Yet we never actually looked to see whether or not RTOG 0129 risk groups were reproducible or validated in other data set. So we looked at RTOG 0129 data. I did this with Quinn Lee. And what we showed first is that the risk groups are indeed reproducible, and at 5 years in 0129, those survival differences persist. And then we used data from RTOG 0522 to validate these risk groups. So RTOG 0522 was essentially a radiation trial to look at the addition of cetuximab to cisplatin and radiation. And what we found is that even in 0522, the risk groups still exist. They're still reproducible, with the low risk group having the best survival. However, what we found that was surprising is that the progression-free survival for the low risk group, the same group that we want to de-intensify, was significantly lower than what we would expect. So at 5 years in 0129, the PFS was 80.3, and in 0522, it was 72.9. So this is the same group that we would give less therapy to, and yet we're trying to maintain the same survival. So this is the first, attempt to reproduce those risk groups to identify the ideal group to de-intensify. So our conclusion was that we should continue with de-intensification. We looked at it in NRG 002 using their eligibility criteria, and they actually had very good progression-free survival. It may be something specific to 0522. Yet to proceed with caution and not reduce therapy too much until we have the initial de-intensification data. What it also tells us is that we could probably have improved risk stratification. So if you look at these curves and these estimates, they're averages. And so you don't know where someone is going to be, right? And it's just like when a patient asks us, what is my survival? And we tell them, we don't know. There's an average. You could be the outlier who does really well, or you could be the outlier who does very poorly. And so, we don't know, but one of the things that we thought of was whether or not we could have improved risk stratification. Especially in the era of de-intensification, wouldn't it be nice for a patient who can balance what their priorities are to determine what kind of survival estimate and decrement they'd be okay with? And so we came up with a nomogram using RTOG 0129 and 0522 data. And this just shows what each of the independent risk factors are that determine prognosis, and it also shows you what the weight is. So the weight of having, being younger with less than 10 pack years or greater is here. And you add them up, and each patient can have their 5-year or 2-year survival probability. You can do this for overall survival, and we can do it for progression-free survival. We have a calculator that's on NRG, and the patients can go on, or we can go on, although I admit I never do it, go on and give patients their survival, a personalized risk estimate. And really the goal of this is to really identify a group who we might really want to de-intensify. So a possible use of this is if we as a community decide that we want at least 90% PFS before we think about de-intensifying those groups. So that would be a potential way of doing it. That's also not a perfect system because the patient populations who go into these clinical trials are probably not the same as the ones who we see every day. So another thought is maybe using biomarkers to figure out who we can de-intensify or maybe intensify their treatment after adjuvant radiation therapy. So I did a study which I had started, I think when I had first started on faculty. It was between Hopkins, and I collaborated with Maura Gilson at Ohio State. And the idea of it was to see whether or not oral rinses could be used to track the tumor burden of patients during treatment. And so We looked at oral HPV DNA and looked to see what the tumor type infection, so the same type that was in the tumor and in the oral rinse. And what you see is after primary surgery, there's a significant reduction in the prevalence of oral HPV infection. And then as people go through radiation, you see a decline. And same thing with patients who go the route of primary radiotherapy. There's a significant decline in oral HPV. So to show you over time, what we did is for the patients who got radiation, they got weekly oral rinses, and we followed their rinses through therapy. And what you see is as they're going through their radiation therapy, essentially this is a marker of their tumor melting away. And you see the prevalence of the tumor type infection declining through therapy, through radiation therapy. Now this is specific to the tumor type infection. When we look at the non-tumor type infection, so an infection that's there but not related to the tumor, you don't see the significant decline. There's a little bit of a decline, but it's not as dramatic as what you see for the tumor type infection. Shown another way, this is a heat map looking at viral load. So the reds are the really high viral load, and yellows are the low viral load. White is we didn't have a sample to test the HPV, for the presence of HPV infection or the viral load. And what you see is that most people start kind of with higher viral loads at the time of initial treatment, and you see a dramatic decline in viral load. And so the titer, so it's not just the presence of infection that decreases, because when you look at presence, there's a threshold, and it tells you whether or not there's an infection there or not. But what you see is that the viral load, the titer of infection actually is reduced through treatment and after treatment. When you look at the non-tumor type infections, so the infection that is not related to the tumor, you see samples that are just red. And so those are not responding to treatment. So when patients ask you, is my infection going away with treatment? The answer is the infection related to the tumor is. But if you have another infection, it's not being treated by your therapy. Now, when we look at the survival differences for those who have a persistent infection after treatment, you see that those who have a persistent tumor type infection have significantly worse survival than those who have an infection that's cleared at the end of their treatment. So this tells us that this is probably microscopic disease that's still left over at the end of treatment. And that applies to both overall survival and recurrence-free survival. When we stratify by local, regional, and distant metastases, you see that it's a dramatic split of the survival curves for recurrence-free survival. However, oral HPV DNA detection after treatment does not make a difference in terms of distant metastases. So we can probably use it to predict local, regional recurrence very well, but we cannot use it to predict distant metastases. So how could we use this? So I think one of a schema, and this is a trial that we're doing with AstraZeneca, is that we will have patients who have been treated who are HPV-16 positive, and then those who have an oral HPV rinse that's positive, or even plasma, because plasma we hypothesize will detect distant metastases better, will go on to either observation, durvalumab, which is a checkpoint inhibitor, or checkpoint inhibitor and an HPV-specific vaccine. And we'll see whether or not we get clearance of infection, which we now know is a biomarker of the tumor, or a precursor of it also, alternatively. And those who are in the observation arm are going to go on to get basically arm C, so they get intensification of therapy. But in a real-world setting outside of clinical trial, if we were ever going to use this, it may be that a PET scan plus this oral rinse might be a way to determine who should get intensification of therapy and who's truly low risk. So the other reason for this is that the good news is we can salvage these patients. Using historic data, oropharynx recurrence was associated with terrible prognosis. We've shown using RTOG data that HPV positive patients have better prognosis even at the time of recurrence. So if we can use a biomarker to have more intense surveillance for patients who we think are going to recur, then we may be able to salvage some of these patients. And this is just data showing using the Hopkins data also to reproduce the RTOG data, So surgical salvage is associated with better survival for patients who have recurrence. So if we have a biomarker and we can have more intense screening for those patients who we think are going to recur, we may be able to save them early. Sorry, I realized this earlier. Some of the slides I have hidden are still showing up. All right, so HPV positivity confers good prognosis, but it's still a cancer. So can we change the incidence curves, and can we apply the lessons that we have from successful HPV detection in cervical cancer and a successful public health campaign of pap smears? So I think the important questions when we think about secondary prevention is, can we detect the disease earlier in a preclinical phase? Do we have an intervention that's actually going to change the outcome, or are we ultimately doing the same thing? And will we improve outcomes in a cost-effective manner? So we looked at pap tests to see whether an oral pap test equivalent could be used to detect oropharynx cancers. And I'm not going to go through the whole study, but basically it was not useful. And our thought on that was that we could not directly visualize the oropharynx tumors. If you could visualize it, then the pap test was strongly associated with diagnosis of oropharynx cancer, and you can identify HPV in those pap tests. But if you look at a high-risk population like HIV-positive patients who have very high prevalence of oral HPV infection, we found nothing but ascus in that patient population. We did not find any cytologic atypia in those patients. So we hypothesized that maybe ultrasound could be used to have more direct visualization. And so we've developed techniques to use ultrasound, and we've taught our technologists who now actually do it regularly so that we can look at the tonsils and the base of tongue. So it's outside of the normal orthogonal planes that we're used to, but you can see here, this is a cadaveric cross-section of the tonsil, base of tongue, and you can see that it's reproduced using ultrasound. This is a CT scan where you get soft tissues that kind of collapse on each other, and it's hard to see. And this is a base of tongue tumor. You can see the fronds on the ultrasound, and this is with coronal. This is the CT scan, which does not readily show you the same information. So when we think about secondary prevention, a pap test is not going to work for oropharynx cancers. Can we identify, but let's say we had a good test, and let's say we could use some sort of imaging to identify it. Could we identify a high-risk population who we'd want to screen? And is there an intervention to reduce the development of malignancy? So we looked at NHANES data, where you have a cross-section of the United States population with detailed sexual behaviors and oral HPV detection to figure out who would be a high-risk population. And so right off the bat, we can see that women have lower risk than men, which is consistent with the incidence curves that I showed you earlier. And then when we look among men, we look at number of oral sex partners, and then we stratify by tobacco use, we find that even in the highest risk group, only 4% would have HPV-16 infection, which is the infection that causes the overwhelming majority of oropharynx cancers in the United States. And then if we look at SEER data, so we take the NHANES data and look at the SEER data and figure out what their lifetime risk is over the next 20 years, even among men who we know, this is kind of where the median age is for onset of oropharynx cancer, we see that their lifetime risk of diagnosis with oropharynx cancer is small, right? And so that makes it very difficult to screen patients, because not only do we not have a good test, but we don't have good imaging, and we don't have a population to enrich for. This was a back of the envelope calculation that I did with Anil Shettervedi and Maura Gilson to think about, if we were going to go into a screening paradigm in the United States, what would it look like? And the bottom line is the number of individuals needed to screen to identify one oropharynx cancer would be 10,500. So those are very hard numbers to wrap your head around and make it feasible in the United States. Now, let's say we had a population that we knew was going to develop cancer, we could enrich for it, we could test for it, what would we do with those patients? So we asked this question. We looked at the Danish Cancer Registry, which is essentially a prospective study because they have, data for all their citizens. And what we showed here is that tonsillectomy rates had declined over time while oropharynx cancer increased, although I will caution you that these are two different y-axes, so they're not actually overlapping. So the incidence of oropharynx cancer is much lower than the incidence of tonsillectomies at a population level. And we were asking the question, could you do a tonsillectomy and would it reduce the risk of future development of tonsil cancer? And indeed, tonsillectomy reduced the risk of diagnosis with a tonsil cancer. So if we had a population who we knew was going to develop tonsil cancer, then that might be a feasible intervention, but obviously we're not doing that on anyone, right? So then in terms of testing, what kind of testing would we do? We are starting these studies for screening in the United States, yet we don't have an oral rinse assay that is CLIA certified and available in labs as it is in cervical cancer. So in cervical cancer they use, or cervical HPV testing I should say, they use Roche Cobas, and then they have the AFTMA test, which is an E6, E7 mRNA detection. We have been using in all of our research studies for the most part, 2 gold standard labs which are not available for clinical use, and they're PCR based. And so we did a study to evaluate how well these biomarkers would do if we're going to apply them to the screening setting. The other candidate biomarker is multiplex serology, and it's done in Heidelberg in one lab. So this is a study where we put together cases, controls, at-risk patients, and you can see here that there was the gamut of sexual exposure across this study population. And so to cut to the chase, how did these biomarkers do? When we look at sensitivity for HPV positive oropharynx cancer, we use PCR-based testing. It only catches about 50% of HPV positive oropharynx cancers. It has high specificity, yet pretty low sensitivity. When we use Cobas DNA testing, which is a commercially available test that can be done in pathology labs, and they're already doing it for cervical cancer, the sensitivity decreases even further. When we look at E6 and E7 antibodies for HPV-16 infection, we see an increase in sensitivity, and we're pretty stable in terms of specificity, meaning that we wouldn't have any false negative tests. And then we looked at a few scenarios of co-testing for HPV-16 in terms of oral rinses and serum antibodies, and there are a lot of numbers here, but the bottom line is, even in the scenario of co-testing, the numbers, best case scenario, are the same as E6 antibody sensitivity and specificity. While E6 and E6 antibody is promising, we just put this in here to show you that you don't get great concordance. While you have a kappa, that's pretty good. I think it was like 0.8 across the tests for individuals. When you look at participants and what biomarkers they were each positive for, you don't see redundancy across the biomarkers. And so there's high discrepancy across biomarkers for these tests. And then when we looked in a screening population, so mouth screening population is mostly at Hopkins. We have some patients who have accrued at Mount Sinai, and what you see is the prevalence is remarkably low. And these are individuals who have greater than 3 sexual partners and have a smoking history. So we've really tried to enrich the population, and yet we still have very low prevalence of these biomarkers. HPV-16 E6 antibodies, only 2% of the population who is thought to be increased risk would have it. That being said, E6 is our best biomarker. Amy Kramer has done numerous studies now showing that E6 is our most robust biomarker and precedes the diagnosis of oropharynx cancer. She's done this in several Norwegian nested case control studies. And what you see is that the titer increases over time in those who seroconvert. Those who are positive are consistently positive years before diagnosis with oropharynx cancer. So if we were to find a biomarker-driven test for screening, we would want to have high specificity to reduce the false negatives, yet high sensitivity to not falsely assure patients. We need a validated test, and we're still kind of far from it as a field. We need something that's widely available, safe to administer, and that's reasonable in costs. And then, as I've said a few times already, we need to remember that ultimately what we need to do is reduce mortality, morbidity, reduce the lead time, and not increase psychological harm by telling people you might have a biomarker which may lead to cancer, yet we have no intervention for how to reduce that ultimate outcome or to reduce the morbidity of that treatment. So in conclusion, incidence of oropharynx cancer is increasing among men, whites, in recent calendar periods. While we previously thought it was among young men, it is also increasing among older age groups. The prevalence is increasing across race and gender groups as well. HPV-related oropharynx cancer is distinct from HPV-unrelated oropharynx cancer, and HPV positivity is associated with prognostic risk factors, prognosis, which is decreased by smoking. There's heterogeneity across the risk groups, so while that's a good way of risk stratifying, there might be alternative methods of risk stratifying our patients, and it might be personalized using a nomogram. I think there's still a huge opportunity for us to improve our risk stratification to identify who's truly at low risk and who we really should be de-intensifying. Tonsillectomy may reduce the risk of diagnosis of tonsil cancer, but it's not ready for prime time. And you have to think about the base of tongue too, because we'd have to do a huge mucosectomy if we were really going to do that. And so there might be a role for secondary prevention, but we're very far from it. And so we have clinical studies evaluating screening now. We have one. MD Anderson just closed theirs, I think. So this is our mouth study. So if you have any interested people who would like to accrue, we're looking for 2,000 patients or healthy individuals who are increased. And I just want to say thank you to all my collaborators, and thank you again for this invitation. It's a huge honor to be here.